Good afternoon, London. My name is DiTulio. Now that you have learned much about chronic inflammatory response syndrome, my job is to add to your academic load this afternoon by reviewing conditions that are often triggered by or concomitantly present with CIRS. And thus, the title of my talk today is CIRS, Associated Illness and Downstream Effects. I have no financial disclosures to make. My background is that I'm a certified family nurse practitioner and have been for 29 years. In that role, I had an independent, full-time primary care family practice for 26 years. I've just given that up a year ago to spend my time more focused on CIRS and related environmental illness. I hold a master's degree in science and a doctorate in nursing practice. I'm Shoemaker certified and have been for 10 years. I'm a member of the State Legislative Commission to study environmentally triggered chronic disease in New Hampshire and have been for 5 years, and founded the Northeast Environmental Illness Alliance, which is an informal group whose goal it is to keep a lot of clinicians up to date on changes in the CIRS protocol and look at other environmentally acquired illness as well. And I was a founding diplomat and treasurer for the International Society for Environmentally Acquired Illness. Learning objectives for the current lecture: to define chronic inflammatory response syndrome, something that all of you are likely able to do already. To identify health conditions commonly triggered by CIRS, those things that would not be there if the CIRS actually hadn't existed. Describe the symptoms associated with these health conditions, and also additional diagnostic testing that you might need to determine the condition's severity. We also have a situation where patients can have existing conditions that are either realized or unrealized that complicate the CIRS situation. It's important to know what those are so that they can be on your radar and on your differential list. It is very important to appreciate that you do not need to be an expert in these areas that I will be reviewing, nor do you even need to know how to diagnose them. But it is important that you know about them, because if you have a situation where your patient is not improving with the protocol, or they're improving in some areas and some symptoms and not others, it's incumbent upon you to really evaluate, to look and see whether one of these other conditions might not be present. And so to review, chronic inflammatory response syndrome is a condition of innate immune system activation triggered by biotoxins, and there are many biotoxins that can trigger CIRS. For the purposes of this conference, we're talking about a mold primarily. Identified by the genius of Dr. Richie Shoemaker in 1997, and subsequently developed a well-defined diagnostic protocol involving symptom clusters, exposure history, proteomic markers, genetic susceptibility, and most recently our gene activation study. The condition characterized by incredible dysregulation, leading to hormonal, nervous system imbalance, immune system imbalance, and hypoxia. And the resulting systems chaos serves as a trigger for the other conditions that I'm going to be talking about today, the downstream effects. And unidentified pre-existing conditions can often complicate the recovery, as I said. So by now, you all should have seen this single-page description of the pathophysiology of CIRS. And it is not surprising that a condition that creates such chaos in the nervous system, the immune system and the endocrine system with dysregulation could be responsible for triggering other conditions. Known direct side effects and consequences of CIRS are outlined here. Issues with sleep, gut health, inflammation, hormone production, pain management, and oxygen delivery. The symptom clusters reflect much of this. When CIRS is being treated and certain symptoms are not improving, you must consider that one of the other conditions that we'll be reviewing might be present. In my own practice, I keep a review of systems and symptoms that I do each visit. If I find that certain symptoms are not changing, they're not getting worse and they're not getting better, they simply are unchanged, those are the symptoms I might look at more closely to investigate whether or not there is not some other condition that's contributing to them. The first downstream effect that I'd like to discuss are the acquired connective tissue problems, largely as a result of the inflammatory attack by the cytokine storm presented by CIRS on ligaments and tendons, our structural support system. Especially in patients who have had CIRS for a long time before being diagnosed. And that can take years and years to get a proper diagnosis. All this time, the inflammatory attack on ligaments and tendons is going on, and they are suffering integrity problems from it. Ehlers-Danlos syndrome is an inherited disorder. There are many types. We see type 3 most commonly in CIRS. The hallmark is hypermobility, also associated fragile skin and stretchy skin. Your CIRS patient who is recovering from their CIRS but continues to have persistent severe joint pain might be someone who you want to actually do your own risk assessment for hypermobility, and that's called a Baton score. And these are some very simple maneuvers that you can instruct the patient to do, even on a virtual visit. It's a simple scoring system, total of 9 points. And if the score is high, then it tells you that the risk that there could be an EDS syndrome present is more likely. Cranial cervical instability, of course, in the neck region is the worst case scenario in terms of stability of the cervical region. At its worst, the head is somewhat like a bobblehead on the upper spinal column, and even small movements of the neck can create intense pain. If CCI is not identified appropriate by the clinician, then and the person is sent for traditional physical therapy thinking that we're just looking at paravertebral muscle spasm, the traditional physical therapy will make them worse. So one way you might be suspicious that CCI is present is if the patient is sent for traditional physical therapy and they actually do worse. At the other end of the spinal column is the tethered cord syndrome, as a result, again, of effects on soft tissue. You have a situation where the spinal cord abnormally attaches to the spinal canal. So in your patient who is being treated for CIRS, but has persistent back pain and lower extremity symptoms, you might want to consider that they could have this kind of scenario. The next downstream effect I'd like to discuss is dysautonomia, defined as dysfunction of the autonomic nervous system, which impacts our involuntary functions of heart, respiratory rate, blood pressure, digestion, and sleep cycles. Certainly anyone with CIRS is likely to have some degree of dysautonomia. However, when the severity of the dysautonomia is such that the patient is at increased risk for injury or harm, then it's incumbent upon the clinician dealing with that patient to identify that and to try to intercede to prevent harm or injury. When syncope or near syncope are problems, and the clinician adds minerals and electrolytes to try to support their fluid regulation, and that is not sufficient, then further medical support may be required to supplant underproduced adrenal hormones. There are many types of dysautonomia. The most common type seen in CIRS, postural orthostatic tachycardia syndrome, is characterized by symptoms when standing and heart rate changes with position change. A patient could be given a tilt table test to diagnose POTS, or the clinician in their office can actually record heart rate changes with position changes to get an idea of whether or not they were terribly dysregulated in this manner. Our vagus nerve, our 10th cranial nerve, bears a lot of responsibility for these functions that are listed. And there is a lot of literature on vagus nerve dysfunction, and there are actually strategies that can be attempted with patients to try to heal a vagus nerve that has become dysfunctional. CIRS is a common trigger for histamine dysregulation. It goes without saying that histamine overexpression triggered by CIRS plays a significant role in the inflammatory process. Dr. Shoemaker, having identified the role histamine plays in CIRS, added 2 histamine-related genes to the gene activation study we call GENIE. A significant number of my CIRS patients have plasma elevations of histamine and or tryptase, and even some without these elevations in the blood have clinical evidence of overexpression of histamine, especially in the skin, the gut, and the brain. We know that histamine is produced and stored in most granulated cells, mast cells, basophils. And we know that associated symptoms can be significant. Certainly itching is a hallmark symptom for histamine overexpression. But all of these other symptoms can occur as well. If the clinician treating the CIRS patient can appreciate that some of the symptoms are related to histamine and can intervene with dampening down some of that overexpression, you can help your patient to feel a lot more comfortable in the short term while you correct their CIRS. This diagram illustrates how incredibly significant the problem of histamine overexpression can be. We do have many well-researched over-the-counter supplements and prescriptions that can help mute histamine effects. Louise Carter, your host for this conference, is quite expert in all that is histamine and has spent a great amount of time looking at this issue with the GENIE tests and in terms of influence on illness. And then we have the gut issues, so prevalent in our CIRS population. As previously stated, histamine is a significant player in gut inflammation. As a result of this and inadequate regulation from alpha melanocyte stimulating hormone, or our friend MSH, sometimes overuse of antibiotics, patients often have imbalances in the gut microbiome. So you will see evidence in testing of Candida colonization, in testing of the presence of small intestine bacterial overgrowth, these bacteria that migrate from the large intestine up to the small intestine and don't belong there, and create a lot of gut symptoms of bloating and diarrhea. Leaky gut, often associated with low MSH, can create significant situations of food intolerances, and as a result, thankfully not commonly, but some CIRS affected individuals who have leaky gut of significance will be able to tolerate very few foods until that situation is corrected. CIRS definitely can be a trigger for autoimmunity. You've probably learned this week that with CIRS, there often is a reduction in healthy T regulatory lymphocytes, whose responsibility it is to help us prevent turning on an autoimmune gene. When there is suppression of these protectors, autoimmunity is more likely to occur. So we see a fair amount of thyroiditis, inflammatory bowel disease, both colitis and Crohn's, psoriasis, psoriatic arthritis, rheumatoid arthritis, pediatric acute onset neuropsychiatric syndrome, or PANS, certainly can be triggered by CIRS. There are other triggers as well that need to be evaluated if your patient meets criteria for PANS. Sometimes underlying tick-borne illnesses are present, or strep colonization on tonsils or throats. And of course, von Willebrand syndrome, part of the CIRS protocol for testing, factor VIII dysfunction can certainly occur in patients with CIRS. Now, interestingly, sometimes with treatment of CIRS, we can see a reduction or resolution of the autoimmune process. So sometimes very high levels of thyroid antibodies actually come down quite low, and in some cases can actually go away. The other conditions, less often do we see a reversal of that autoimmune process, but we can certainly see with CIRS treatment much better management, easier management of these conditions. Other concerning downstream issues are many, actually. Pulmonary artery hypertension, an area that Dr. Shoemaker has spent a tremendous amount of time publishing, and stay tuned for the most recent article to be published, can turn a triathlete into a heart failure patient in terms of their ability to produce energy, a very serious consequence of CIRS. We also see hypercoagulation. Those folks that are able to get Gini tests done, this would be the gold standard in identifying how significant or worrisome the hypercoagulation state was. For those that don't have access to Gini, we certainly have a panel of blood tests that can be done to assess for problems with increased risk for clotting. Metabolic acidosis, we can use blood tests to determine anion gap and follow patients to see improvement as CIRS is treated in their metabolic acidosis. If we have the luxury of a Gini test result, then we are going to see the evidence of the hypometabolism and metabolic acidosis on that Gini test if it's present. Downstream issues of chronic pain and chronic fatigue and cognitive impairment, three of the hallmark issues symptomatology-wise with CIRS patients, and complex reasons why they exist. Mood disorders, whether you're talking about brain on fire and neurotransmitter dysregulation from that inflammatory process, whether it's histamine creating the inflammation in the brain, creating mood disorders. We certainly know that the newer concept of brain on ice, where there is reduced oxygen delivery to brains, particularly when VEGF is low, the vascular endothelial growth factor, there's a lot of literature about low VEGF and psychiatric disorders. So these are complex areas where multiple factors can be coming together to be creating the effect. Erythromelalgia, or EM, our own Dr. Lauren Sparks is the group's expert on EM and its association with CIRS, and is doing some research currently, and hopefully something will be published down the road, defining the association between EM and CIRS. Symptomatic Chiari malformations. So we have situations often where people have a structural risk for having a Chiari malformation, which is where the cerebellar tonsils are pushed down into the spinal canal, creating symptoms. Someone can have a smaller canal structure, which would put them at risk, and then they acquire CIRS, develop cerebellum swelling, and then you have that downward pressure, and now you have a symptomatic Chiari malformation. The hallmark for those folks is typically intractable headache, often starting at the base of the skull and going up over the head. So if you're treating your patient for CIRS and they are then continuing to have this headache situation, you certainly would want to either refer them or certainly order an MRI of the brain, which will usually define whether that issue is occurring. Now we want to talk about situations or conditions that are not triggered by CIRS, but are present concurrently in certain persons with CIRS. And a big category for that are tick-borne infections. And we know that tick-borne infections are widespread and common. We know that the 5,000-year-old mummy in the Alps, when his bone was tested, had DNA evidence of Borrelia on board. So we're not talking about anything that is new. Often when tick-borne infections are present, because testing is insensitive, patients are unaware of that diagnosis. Dr. Shoemaker covered for this particular scenario with Lyme disease in that the protocol calls for pre-dosing fish oil before binding in persons who would be considered high risk for Lyme disease. People who live in endemic areas, people who have had multiple tick bites without diagnosis of Lyme disease. So there's a lot of scenarios where a person would be considered high risk, and for them, before you start to treat the CIRS with the binder, with the CSM, you would pre-dose them 10 days in advance with fish oil to help alleviate or mute that expected rise in MMP9 that we would see if that were not done that way. So there is an understanding of the risk for having these underlying infections present and not know it. A common scenario that I've seen here in the Northeast of the United States, which is an endemic area for tick-borne illness, so a lot of experience in this arena. I'll have a patient with CIRS who is doing very well. They're in their good environment. They're taking their binder. Each week, the update is a positive one. They're getting better. They feel better. Ultimately, I haven't felt this good in a long time, only to be followed in some cases by an email or call that says, "What just happened? I feel horrible." And often that "what just happened? I feel horrible" is actually the immune system having improved its organization so much that it's able to see atypical infections that it couldn't see before. So in those cases, the person is tested with C3A, tested for various infections, and sure enough, usually something shows up at that point because the immune system is doing a better job at making antibodies, where before it was too disorganized to do that. And once the immune system is reorganized, the treatment for tick-borne infections is fairly straightforward. The problem with treating tick-borne infections in someone who has CIRS and is not treated for the CIRS is that you will see many of these people being treated for extended periods of time without improvement because they have such a disorganized immune system. And the other problem is the second piece on this slide, which talks about post-Lyme disease syndrome. HLA haplotypes 15651 and 16551, and also your multi-susceptible haplotypes that aren't listed here, pose a dilemma for a patient being treated for Lyme disease in that they need help clearing the die-off. They need help because their infection will trigger a CIRS event. And so, again, many people who are treated for Lyme disease by people who are not CIRS literate will be treated for a very long time without a binder, and they will continue to have persistent symptoms indefinitely. So very important to know HLA status in anyone you're going to be treating for tick-borne illness. And the last area of concurrent challenge in a CIRS patient is that of heavy metal toxicity. Heavy metals are a worldwide problem and an underappreciated problem by conventional medicine as to their role in neuroinflammation and certain cancers. The research on the effects of heavy metals is abundant, but not necessarily translating into practice. But it is important to do a good exposure history to target testing. It is not frivolous to do a basic blood panel for current exposure on any of your patients who on their CIRS symptom checklist identify areas of cognitive impairment. Something as simple as aluminum. If you have a patient who has not yet been informed that aluminum-based antiperspirant use, especially in someone who does not clear toxins well, can become a toxic exposure and can create high levels of aluminum in blood and tissue. I see this not so much anymore as years ago because the word has gotten out there that people should not be putting aluminum under their arm every day that they live and breathe. Issues with arsenic, which is a naturally occurring metal in the northeast of the United States where I am. We have significant arsenic problems. We are here in New Hampshire, the Granite State. So our well water is often very high in arsenic. Arsenic is both a carcinogen and an inflammagen. So New Hampshire, for example, has in the United States per capita the highest rate of bladder cancer in the country. And the cancer associated with arsenic is bladder cancer. So you certainly want to know, you want to do an exposure history for your patient and target any testing based on their history. But understand that depending, if you're downwind from a coal burning factory, uh, you're going to have exposure in the air to many of these metals. And that can then certainly impair the ability to recover as quickly from CIRS in the area of cognition. So always be aware that these things can be an issue. I would like to thank you for your attention. I hope that you've learned something new here simply about other conditions that can be present with CIRS. It was meant only as an overview and introduction. Any one of these areas could easily be an entire lecture of its own. But be aware that these are situations where you might want to call upon colleagues that do more work in this area. There's always people that can help you if you're not sure. And good luck with your conference. And thank you very much.